Thank you, Dr. Shirazi. Good afternoon, everyone. Good afternoon, all the delegates. So today's topic, we'll be dealing about how to manage difficult behaviors in autism. And we know that autism behaviors are something which are very, very difficult to manage, even for the parents, for the professionals. So this lecture, this webinar will be all about how to differentiate between a typical behaviors in a neurotypical child and how to differentiate the behaviors of an autistic child. And when it comes to autistic behaviors, how we can manage them. So some practical aspects and some background, how to approach them. So I will start with the session now. So managing difficult behaviors in autism. And I would request participants to please kindly mute yourself. So first of all, when we start with the management of difficult behaviors in autism, first of all, we should know what are behaviors. So if I define behaviors in a very simple way, behaviors are just defined as the way how we present, how we conduct oneself and especially towards others. So how we interact, how we behave, how we respond to them is what we call as behavior. Now, again, behavior is something which is different to different people. Some may react in a different way, some other might react in a different way. But the most important thing is what we need to understand is that behavior causing any harm to other? Is it being socially accepted? Is it injurious to the other? Is it injurious to the person who is creating the behavior or causing the behavior? So all those things need to be differentiated. So first of all, when we come to an autistic behavior, how we can tell whether this poor behavior or the behavior is a result of autistic symptoms, or it is just an ordinary naughtiness, or it's a simple tantrum which we normally see in the toddler age group. So it's not always very easy to differentiate an autistic behavior from misbehavior, because many a times children may be on the spectrum might present with the behaviors, though it might not be typically presenting as an autistic behavior. So how we can differentiate whether it is a true autistic behavior or it is a misbehavior? So many of the behaviors that are typical of children on the spectrum might deem discipline problems in other kids. It's very true. Many a times, most of the kids, children on the spectrum might cause behavior disturbances, which might trouble to the other set of neurotypical or developmentally growing children. So how these children on spectrum present with these sorts of behaviors? So these are some of the examples that I have put across. Kids with autism may scream or yell when they are overwhelmed and frustrated. It's a very normal thing which we see, that they are very much oversensitive to the stimuli. They get overwhelmed with the simplest stimuli, which are much not at all affecting the neurotypically growing children. So some autistic children may bolt from the room, they may hit others, may injure themselves. Some may rock, flop, may do head banging, may do head tossing, may be running here and there, may do toe walking, may not sit at one place. So in many of the cases, sometimes it may become so injurious that they may cause hitting themselves, they may bang their heads, they may rock their heads, they may pull the hairs, they may scream, shout, and may throw things. So all those things represent all these different types of behaviors which occur in an autistic individual. In school, children with autism may over or underreact to other requests or needs. For example, if a non-verbal child is there in a school and he wants to go to a toilet, or he is not able to explain that I have a tummy pain, how he can do that? He may start showing all sorts of behaviors, like he may start tapping on the table. He may start pushing other kids. That may be a simple reason that he wants to gain an attention, so that someone could look at him and they may be able to express non-verbally, either by pointing or gesturing. So these indicates all sorts of different types of behaviors and the need why the child is doing it. So these are the different types of presentations which a child does on the spectrum. Now, if I broadly, we'll be discussing in the different future slides, in the subsequent slides, but the most important thing which needs to be understand, whether it is a neurotypical child or whether it is a neurodiverse child, there has to be a cause for behavior. A behavior in any person will not happen unless and until there is a cause behind it. So if I come across the causes for behaviors in a neurodiverse kid, or specifically talking about the neurospectrum or the neurodiverse spectrum, the result of most of the causes of behaviors in autism happens either as a result of sensory, either as a result of communication deficits, behavioral, or attention seeking. And the most important thing is medical causes, which needs to be ruled out at the last, because the majority of the causes which happen for behavior are either sensory or communication deficits, or as a result of sensory or tangible behaviors. That is, tangible means a demand, they need a something for it, and the reason for that is because of that they are causing a behavior. So in that case, we need to differentiate whether it is a true temper tantrum or it is a sensory meltdown. So that we'll be discussing again in the next coming slides. So these are some of the most common causes, and whenever we are managing a behavior, we need to figure it out that what is the cause rather than jumping on the target behavior. So difficulty responding to kindness. But yes, it's very true. It's very, very difficult for the children to respond politely to others. Just for example, I have given you some very common example. For example, a grandma comes to visit. She tries to go to the autistic child and wants to open and tries to hug her. But what happens? On the contrary, then or the spectrum child runs away from there. The grandma runs towards him, so because she wants to hug her, and in return she gets a kick on his shins. So what is the response? That the child on the spectrum kicks her, and the grandma would be very surprised that why does that happen. So but it's not that reason the child is not able to respond to them in a kind, it's just that it doesn't like the hug. So instead of directly now what would have been approach in this, we would have tell, oh, how this notorious child, how does he behave, he doesn't know how to behave with elders. But probably we are not able to figure out the cause, why did the child do that, or why did he does it retrospectively in this kicking the mother on the grandma kicking with her. So the all those things need to be understand. That is why we always talk about looking for the antecedent factor causing the behavior rather than targeting the behavior itself. So these are some of the things which I have discussed. So all these behaviors need to be figured out regarding the causes rather than jumping on the target. So let's come about what are the sensory challenges which a child on the spectrum may face, as a result of which he might show a behavior. Now, as I've given you an example in the previous slide, the grandma came to hug her, and the child ran away from there. And she ran behind her and tries to, and in the return, the child kicked her. Now, what was the reason why the child could have run there? One of the reasons which we can thought of, that child could have been run because he was not able to tolerate that smell of a perfume of the grandma. But unfortunately, how many of us would have thought that? And so that is the most important thing we need to understand. Probably he might not be able to feel the smell of the sense of that perfume, because we know they get very overwhelmed very easily by these smells, perfumes, or surroundings, and even the slightest change in the environment might cause them the sensory meltdowns. So that is the variation of sensory challenges the child on spectrum can face. Another child, sometimes again another thing, the grandma might be coming to hug her. She doesn't like, she's again trying to hug her, and in return he pushes her. Probably he doesn't like that hugging, he doesn't like that kissing. He's not comfortable with that. It could be because the child might be having tactile issues. On the contrary, some children are there who might be like hugging a lot, they might be cuddling a lot. So all those things need to be understand, because they might be under responsive, they might be seekers, or they might be hyper responsive to that particular sensory stimulus. So those things need to be taken into consideration whenever we are looking for the behaviors in a child. So sensory challenges may also be the reasons behind misbehavior, as we have told. When in a crowded or loud auditorium squeezed between the people, the child might not be comfortable. Similarly, when he's going out in a mall, when there are so many bright lights, he might just scream out. He might just run away from there. And probably we will not be able to figure out what is the reason for that. Either he might be not comfortable with the sounds, so much crowd noises. He might not be comfortable with the bright lights. He might not be comfortable with the touches of the other people which is getting during in the mall, in the lifts. So all those things need to be tackled and answered before you just jump on the target. So ask, watch, and keep a tab on behavior. This is very, very important, that ask, watch, and keep a tab. Or you can say in another way, ABC, ask, that is antecedent. What was the factor which caused the trigger in the behavior? What was the factor or the trigger which caused that behavior? And then you watch, how is the behavior happening, what does the child is doing, how he is responding to that stimulus, and what is his response. And then accordingly you keep a check on the behavior, how to manage that, provide him a consequence. Now those consequences can come out either in the form of positive reinforcement, negative reinforcement, punishment, or extension. So these are the four broadly classified consequences when we do. So a golden, standard approach is ABC: antecedent, that is ask; B is behavior, watch for the behavior; and C, you provide with the consequence either in all these four steps. You break down the consequence, whether you want to give him a positive reinforcement, you want to give him a negative reinforcement, whether you want to give him a punishment or extension. That means keep a tab on the behaviors, how you want to monitor it and provide the consequence to end the result, to end that behavior. So this is how we need to approach. But majority of the times we just target on the behavior, that is we jump on the step B, behavior, rather than forgetting the step A. So other challenge, other causes of behavior besides sensory challenges is social communication deficits. So everyone with autism has a very tough time with social communication at one or every level. We know that. And it's even not possible to read their emotion, because we know that they are very poor in facial cues. They cannot understand what is their facial expression. They might be not able to understand whether it's a sarcastic comment, or they might take it in a very little meaning. So it's very difficult for them to watch and imitate. We know that imitation is very, very poor. We know that eye contact is poor. They are not able to maintain a good eye contact. They're not able to imitate others. They have a poor joint attention skill. So as a result, it becomes very, very difficult for them to watch, observe, and understand the facial cues of others. The mother might be very, very angry with the child. The mother might be, his head frowning might be there. He might be looking in a very annoying way. But unless and until mother gives him a slap, he won't be able to understand that. That's what we talk about facial cues. The mother might be very, very upset due to some circumstances which might happen in home. She might be in a very bad mood. She might be just feeling upset, low. She might not in a good mood to talk. But a child on the spectrum might not be able to understand all those facial cues and might go there and hug a mother and might be able to, if not verbally, but at least give her a hug and understand. For him, it will be just a same old day. He might be busy in his old task, or he might not be able to understand those emotions. So this is what we know as social communication challenges with the child will face. Because communication never always means verbally. There are some other things which we talk about non-verbal communication. And that is exactly where the problem comes. That is, non-verbal communication challenges are much, much higher in children with spectrum. That is why there is no pointing. That is why they just do hand lending rather than do a proper pointing. That is why they are not able to read the facial cues. They are poor in understanding the facial expressions of others. They are poor in imitations. They are poor in joint attentions. So all these factors contribute to what is known as social communication deficits, rather than telling social communication non-verbal communication deficits. So how we can tell you that the child is having difficulties with social communication? So as I have told you all these examples, and that is what exactly written. So first and foremost thing is, now whenever you are giving for another social, the most important thing now here is how you communicate with the child, because we know that they have social communication deficits. For example, if you tell a child, go to the kitchen. Now, this is just a single word command, go to the kitchen. Now, for him, go to the kitchen might be so much overwhelming response to him that he might just run away from there. He might just throw things. He might just bang his head. He might run away from there, because it all varies from a child to child. Now, if I make 3 to 4 kids stand on a row and tell them go to the kitchen, a child on the spectrum might go after 5 seconds. Another child on the spectrum might go after 10 seconds. Another child on the spectrum might not go at all and may just go in a sensory meltdown and run away. So that is what, again, this communication challenges might vary from child to child. So in that case, how you have to give the instruction is a very important thing, what is known as discrete trial training. I'll be coming on to that. So whenever you are giving instructions to the child, rather than giving an instruction, normally what happens, we tell, go to the kitchen. He doesn't listen. Again, we tell, go to the kitchen. It doesn't listen. We shout at him, go to the kitchen. And the scenario happens so much that both of them, the mother and the child, gets frustrated and the task is not being done. In that scenario, what should be done? The first and foremost step is you need to take an eye contact with the child. Unless and until the child doesn't give you an eye contact, there is no point in giving a command. Once the child gives you an eye contact, give a command in a very simple and specific way. Go to the kitchen. It should be clear and crystal, because we need to understand that abstract language is very, very poor for children on spectrum, as we have discussed in our previous webinar. So then you have to wait as per the discrete trial training. We'll discuss on that. You need to wait for at least 30 seconds for the program to get registered in the child. Normally what happens, we say go to the kitchen, within a period of 5 seconds. If it doesn't, we again repeat. We keep on repeating, we keep on repeating. Now this continuous repetition gives him an sensory overload to the child, and that results in a probably in a sensory meltdown or overwhelming response to the child, and as a result he might ignore, he might get irritated, he might run away, he might show behaviors. So these needs to be tackled while doing or managing behaviors in a children in respect to communication deficits. So other behavior challenges, again, autistic behaviors are usually self-evident because they are generally quite different from typical behaviors. Now, another most important thing is when we come to difficult behaviors, now normally there are some of the things which we will see that these are some of the things which we normally see in a child. Stimming. Now, stimming is also a type of behavior. Now, why does a child do stimming? Stimming, normally for us, we might feel that stimming is a very bad behavior for the child, for him. He is continuously being involved in rocking. He's continuously being involved in hand flapping. He's being continuously looking and staring to the fan. He's continuously being playing with the sand. Now, basically, stimming is also known as self-stimulation. Now, it is a calming technique for the child. And normally, if you observe closely, that why does the child do stimming? Stimming is a behavior. Now, normally what we do, we go and try to stop the stimming. We will tell, don't do it. We will go make it, we will snatch the thing. We will make him do some other activity. But stimming is a type of behavior which is happening because of an overwhelming response or oversensory overload which has been gone into the child's brain. As a result of it, he wants to cut himself from that sensory overload. As a result, he gets himself cut off from the environment and goes in a stage of stimming because he wants to bring down his brain in a calming state. It's just like that. For example, if you keep on giving a command to the child, go to the kitchen, or continuously, he's not able to understand that. So he just want to cut off himself from the environment and he just wants to stim so that his brain is cut off from the surrounding environment and the social environment. So that is what is a calming technique to make him down. So in fact, stimming is a calming technique which helps the child to go in a state of calmness. If I talk about in a very simple example for a neurotypical child, if I'm going on a stage for the first time to give a lecture to 200 people, I'll be very nervous. I'll be curling my hairs. I'll be roaming. I'll be to and fro on the stage. But what is that? It's a stimming. Why I'm doing it? Because I'm very anxious. My brain is getting oversensory over him with the response of the crowd because I'm delivering it for the first time. So I'll make myself calm down by walking here and forth. That's also a stimming. But what is the difference between a stimming in a typical child and a neurodiverse child? In a typical adult or in a typical population child or a typical neurotypical child, I will have a control on my stimming. After a certain period of time, I will control myself and will come out from that stimming and start delivering what I have come there. But whereas in a child who is on the spectrum, stimming sometimes goes into such a prolonged state. Sometimes, it's not always, sometimes it goes on to such a prolonged state that unless and until an external force, either a caregiver or a parent or any other, comes and intervene, otherwise the child might go into a stimming state for 24 hours, for 4 hours, for 5 hours, depending upon the severity of the behavior the child is. So that is the main difference, that stimming happens in every person. But when, and there is also a very important thing, do we need to intervene stimming in every child? No. Stimming, as I've told you, it is a self-calming behavior. You need to intervene only and when your academics, your ADLs, activities of daily living, your understanding is being hampered. If a child in 24 hours, after doing 4 hours of therapy, 3 hours of special education, 2 hours of physical, and then he takes some 5 minutes of himself to do stimming, let him do it. It will not cause any harm to him because it's a self-calming technique for the overwhelming response which he has received throughout the day. And even for us, if I do so much work, lecture and there, I will keep myself at one place and will try to mingle my hairs, will rolling my pens, something. So, but that's I overcome with that after a certain period of time because my brain gets relaxed. Similarly, for a child, on a spectrum, irrespective of the severity, if he does stimming for 5 to 10 minutes in a day, and then if you tell him, okay, let's come, John, we'll play this, he comes immediately. Don't worry about that stimming behavior, because that will give him a booster to his brain in order to calm from the overload he has received during the day. So another thing is lack of eye contact. Lack of eye contact, we know there are so many theories for the lack of eye contact. There is a misimbalance between the excitatory and the neuroinhibitor. There is a imbalance between the glutamate and gabamate. So as a result, there is another theory says that also imbalance between the serotonin and glutamate and GABA. We know that serotonin, along with the excitatory center, it also plays a very important role in providing calmness. And serotonin is produced in much more amounts from the gut that compared to the brain. So these are so many theories regarding why the child shows lack of eye contact, self-abuse. In some cases, particularly for people with severe autism, self-abuse is common, like head banging, skin picking, other behaviors. Either they may, again, these behaviors might be intentional, these might be non-intentional, depending upon how much sensory overload, or it might be due to some certain tangible things. So all those things need to be looked into focus why all these behaviors happen in a child. So these are some of the behavioral challenges which a child can face as a result of all these factors which we have discussed. Now let's come to little more difficult behaviors, what we known as self-injurious behaviors. Now one and foremost thing is self-injurious behaviors always needs to be intervened. As I've told, stimming, it does not need to be intervened always, but self-injurious behaviors need to be intervened always. This is one and foremost important thing which should never forget, that don't allow a child to be left alone when he is doing a self-injurious behavior. So what are the examples of self-injurious behaviors? Now, self-injurious behavior is a behavior when a person physically harms himself or others and can cause injury to himself or others, like headbanging on floors, like arm biting, nail biting, scratching, hair pulling, eye gouging, pointing in the eyes, face, head slapping, picking, throwing things, scratching, headbanging, all those things. And about half of the autistic people engage in self-injurious behavior at some point in their life, which can affect people of all ages. Now, many a times when a person or a child comes with self-injurious behaviors, many a times we prescribe them with Suzodon, many a times. And I think most of us will agree with me. But again, the approach would be, my approach would be little different rather than directly approaching, because when we are when we are medicating a child, we are just targeting the behavior. We are just targeting the behavior. Again, just revise your slides. I have told we need to observe the trigger for the behavior. What sort of behavior whether it is a self-injurious, whether it is a meltdown, whether it is a stimming, you need to address the reason and figure it out why the injury, why this behavior has caused. And then probably your approach might be little more better, little more comprehensive, and the result will be much better compared when we directly target the behavior. So what are the causes? Again, the same causes which we have described. It could be attention seeking, it could be medical, it could be sensory, it could be behavioral, it could be communication challenges or tangible behavior. Now, medical causes needs to be ruled out at the last, because many a times majority of the causes are sensory. Majority of them are sensory and communication challenges. But once you are able to figure it out that those are the causes I have ruled out, but probably I don't feel that the proportion of the behavior which is coming, it is related to the sensory issues. So you need to explore the reasons that the severity of behavior is this much, but the child is having the sensory issues only to a level of mild. But I don't think that these set of sensory issues might cause such a self-injurious behavior to the child. Then probably I need to look out into the other causes. How about his communication deficit? Can he able to understand my two-word command? Can he able to understand my three-word command? What is the level of receptive? How does he communicate? If I'm able to figure it out, yes, this is not that level of severity of communication deficit which is causing that much self-injurious behavior. Probably I need to rule out at the other level. Is he able to explain his medical needs? Is he able to explain his colic pain? Is he able to explain my throat is paining? Is he able to explain, are there any adenoids problem in my house? I'm not able to sleep comfortably. So all those things then you need to figure out. So managing behavior in autism is not a very easy task, even for the professionals. And I would say that parents manage behaviors much better than a professional. Uh, the reason is because they are with them at 24/7, and probably believe me, nowadays parents are having so much knowledge regarding this behavioral management, regarding all these things, that probably we as professionals might be, if not less, they might be at par with us in these behavioral things. Although forget about the medication part, but in these things they are awareness is great about the parents, those senior parents whose children are now in the adolescence age group. And thankfully they are doing great work with their children, especially in these behavioral management parts. So these things we always need to be looked out. So the possible causes could be whether they have been not listened to, that is they have been not given attention, they have been rolled off, and they have been thrown off. They might be sensory issues, are they being bullying, they are not feeling unwell, that means they are comfortable feeling unwell. And there might be memories of bereavement, because we know that children on spectrum, they have very sharp memory. So many a times there might be some bad experiences which they might felt. For example, a child might have gone on to a birthday party, and there were so many balloons, and during that birthday party cake cutting, one of the balloons burst, and that bursting of that balloon or the sound might give him a sensory overwhelming response to him, that from that day onwards till now he had never attended the birthday party, or whenever he sees a balloon in the birthday party he just runs away from them. So this is a typical example of memories of bereavement which the child might have faced. So ways of communication. Another thing is how a child might have no other way of telling their needs, wants, and feeling. So as a result, he might do head flapping, he might do banging, he might do pushing others, he might slap himself, and he might do head banging, or he might jumping, he might do hand flapping. It might be his way of excitement. It might be his way of anxiety. Many a times parents complain that वो जब पेपा पिग देखता है movies में या उसमें टीवी में वीडियो में he starts hand flapping, but otherwise he's comfortable. So would you say that it is a behavior? Would you say that it is his stimming? What would you say? It's just if we analyze again. Now the mother has clearly defined. If the mother says वो hand flapping बहुत करता है sir. Now अच्छा behavior है ये तो we need to intervene the behavior. But then you dig into the history and ask वो hand flapping कब करता है? Sir, he does hand flapping when he does Peppa Pig. Otherwise, he is comfortable. He doesn't do anything. He walks on the toes when he's very excited, when he wants a chocolate, or when he Papa comes out during the home in the evening. So that means there is a trigger. So probably it is his way of expression happiness. It's way of feeling excitement. It is way of when he's anxiety, because he is a non-verbal child. He cannot express completely. A neurotypical child might have told Mama, Peppa Pig, I'm very happy. Mama, Papa has come, please give me a chocolate. But that child on a neurotypical spectrum, neurodiverse spectrum, who is not able to communicate, who has communication deficits, might be his way of expression. So that's what we talk about non-verbal communication. But this non-verbal communication is different from the non-verbal communication in a child who is neurotypically or growing. There they will do pointing. There they will do something gestures in a proper socialized acceptable way. But here it is not there. So again, here comes is many a times there is a confusion that there is social communication deficits, and but the child on autism will do non-verbal communication. So non-verbal communicate thing need to be understand is there are also non-verbal communication deficits on autism spectrum. It's not only social communication deficits. Social communication deficits will be present in majority of the kids on spectrum. I would say more than 90% of the kids, or more than 99%. But the problem which is there, we need to understand, we differentiate the severity of the autism spectrum is what is the level of non-verbal communication. That is most important. Whether he does pointing, whether he does hand lending, whether he's not able to explain each and everything of his behaviors, as I have given you an example in this, that he just starts doing behaviors, self-injurious behaviors whenever he feels happy or excited. So these needs to be tackled. Sometimes children may start slapping the ears. They may start slapping the ears or your cheeks when they are get excited, when they're happy. That doesn't mean they are angry. That doesn't mean that they are hitting others. Doesn't mean that they are showing behaviors. It's just a way of showing an affectionate to others or happiness. Also, another thing is sometimes when you are going in a school, the children, the teacher complains, ये बहुत push करता है, ये बच्चों को push करता है, इधर push करता है, उधर push करता है, and teacher immediately complains to the parents, आपका बच्चा बहुत तंग कर रहा है. Teacher comes and they blames the parents, all those blah blah, and everything starts happening, and there's a stress and all those things happen. But probably were we able to trigger out when does he does that? Does he do it in every situation? Does he do it on the playground when there are so many kids they are playing and he's not able to communicate? So he's pushing his way of communication so that please involve me in the game. I also want to be a part of it. But unfortunately, these are considered to be as behaviors, and we target the behaviors rather than jumping on the triggers causing those behaviors. So need to figure out what is the environment, why it has been done, what was the trigger, and then target on the behavior rather than directly jumping on step B. So mental health issues, yes, depression, anxiety, we have discussed. And another most important thing is developmental stages. The child might still do some things that are most kids stop doing at that age, as a hand mouthing, putting their fingers or hand into the mouth causing injury. We know that there is a development delay in children. So mouthing might be a very normal in a neurotypical child in a particular certain age. But that mouthing might happen in a neurodiverse child who is much, much older. So because we know that these things are normal, so every time we cannot take it as a behavior. Every time we cannot take it as a behavior because we know that there is a development lag, but biologically the development stage is also progressing in a child. So a neurotypical child might do mouthing in an age of maybe around somewhere around 18, somewhere around 12 months, 18 months, 15 months, whereas a neurodiverse child might do mouthing at the age of 1 year, might do at the age of 2 years. So there might be a gap because there is a developmental delay. A child, again, for example, there is a non-verbal child who starts speaking words, just started. So he might start doing, who is a non-verbal child. He starts doing babbling by the age of maybe 2 years because he's a speech delay, he's on spectrum. So started doing babbling by 2. But a normal babbling, we know that it happens at this much months of age. So it doesn't mean that he's doing a behavior. So every time we cannot tackle as a behavior that may be sensory or XYZ. So again, they might be a developmental delay, and it's a normal for this child because he has just started babbling. So probably then the speech and other things, manding, joining, mono, bisyllables will gradually come. So because he has started attaining this, he started learning the speech pattern because he's a developmental stage. So that babbling will definitely come at a later stage. So all those things need to be understood before directly target on the behavior. Then another thing, they might be a learned behavior because it's a very human nature that a child will always learn very easy things rather than learning some good things. So they might be a spectrum child might be going to a special education or special school, and he might see 3 4 kids hitting, banging. He might again start doing that. So it's what he call as a learned behavior. So those things always need to be looked. So that is why I'm telling, managing behaviors in autism is not a very easy task. It's practice and practice which makes you understand how you need to approach the behavior in that particular child. Because the more you see the behaviors in child, the more you will understand that what is the reason for them. So what to do? Now the most important thing is what to do. We have learned all those things, how we can do it and what we need to do it. So respond quickly. Your first most important thing is, as I've told you, antecedent. Look, respond quickly. First of all, when there is a self-injurious behavior, you need to intervene at any point of cost because you cannot, your priority is you cannot hurt, you cannot allow the child to hurt himself or others. So intervene, respond quickly, and talk in a very low, polite, and firm sentence. So your command should not be confusing. Your command should not be at a screaming pitch. It should be polite and firm. Now, polite and firm should be in a normal, steady tone with a clear instructions which has been given to the child. Whether that banging, whether that behaviors has been done in relation to some demands, whether it has been done in relation to some triggers, those need to be looked. And then you provide barriers to the child. Most important thing, physical barriers, use barrier because you cannot allow the child to hurt. So use physical barriers. Either you can cover the child, either you can cross the child between your legs like crisscross scissoring it and fix the child, or you hold him with the wrist. There are certain physical restraints which have been given, which are being accepted globally, and physical restraint which you need to do is either you hold the child at the level of the wrists so that he doesn't, because many a time they do hand flapping, hit others. So you hold them at the level of the wrists. You hold them between your legs with crisscross like this. So physical restraints need to be given, or you provide them with gloves, helmets, XYZ, depending upon how severe they might cause. So most important thing is you, whenever there is a physical self-injurious behavior, you need to protect the child. And how you need to protect the child, physical barriers or your crisscross, we have discussed physical restraints, and what command and instruction you need to give to the child, that is also very, very important. So preventing behaviors, as I have shown you, this is the master chart which need to be followed in every aspect of behavior. So this is what we discussed about ABC, that is antecedent, behavior is for the specific, and see what consequence you need to give in. I'll be a little more quick because we have only another 20 minutes to 25 minutes left. So it's a very vast topic, but try to cover it out as fast as possible. So prevention, as I've discussed you, what needs to be prevented, you need to look out in the triggers, whether it is a sensory, whether it is a behavioral, whether it is a medical, whether it is an attention seeking, whether it is a tangible. And then many a times what happens, the child is showing behaviors because he has nothing to do in the daytime. For example, there is a 4 hours therapy. The child goes to the therapy from morning 10 to 1, and after that there is nobody at the home. Mother and father are working. There is only the grandmother. He's not able to look after the child, probably because of the XYZ reasons, and he's just left alone, and he just throughout the day he keeps on hand flapping, stimming, rotating, jumping, running here and there. Sir, he's doing behavior. Sir, बहुत तंग करता है. What to do? Sir, please give him something so that he stops doing behavior. First of all, look for the reason what the child is doing. He's being left alone. He's a 6-year-old child who's in the spectrum. He doesn't know, he doesn't have any skills. He doesn't have any functional skills to do. If I left him alone for 2 minutes, can he do coloring? If I left him alone with can he with the Play-Doh? If I left him alone for 5 minutes, can he do some drawing? Can he do some turning pages? Can he do pasting, cutting and pasting? No, sir, उसको कुछ नहीं आता. मम्मा पापा को recognize नहीं करता. Is the then what will the child do? The child only knows this. He doesn't have any skills. So what you need to do? We need to teach him. We need to provide him with an scheduling. Scheduling is again a very important thing, because when you provide a scheduling to the child, his brain anticipates that my next step is this, my next step is this. Children, autistic brains are just like bookworms. They can, you make them work throughout the day, they will not get tired. But if you left them alone for some time, maybe 4 to 5, as we have discussed, then they might engorge in all sorts of behaviors because they doesn't have that skill. Now, again, it doesn't apply to all set of population, autistic population. It applies depending upon the severity of this autism which the child is having. So you need to provide him with this scheduling. What is known as scheduling? Now, scheduling again gets divided: independent scheduling, then dependent scheduling. Now, in dependent scheduling, again, it needs to be categorized whether it is very substantial dependent scheduling, whether it is minimal substantial, whether it is minimal or whether it is very less. So a child on the spectrum which is who's very, you need to provide a scheduling. 2 घंटे आप कराएंगे ये काम, 2 घंटे आप कराएंगे, 2 घंटे आप कराएंगे, 2 घंटे आप. So throughout the day, and you provide them with the visual charts. Prepare them a chart on the ground. The 9 a.m. to 1 you have therapy. From 1 to 2 you have to work with the mother. From 1 you have to work with the sister. This and this. So believe me, if you provide them with this visual charts and scheduling, his behaviors will automatically correct down. Then if it does the behavior, then we need to look out for the other causes. Sir, हाँ, अब उसके behavior settle हो गया. Why the behaviors have? What we have done? We have just provide them with a schedule. We have just provide, because once he gets routine used to it, they have very much fixations. They are very particular about the routines. Why? Because the autistic brains are provided with such that the neurodiverse kids brains is being provided with that, and use this fixations not as we have discussed previously, use this fixations, use this deficits or the skills, whatever you call it, as a positive rather than as a negative, because they are very much particular about the fixation. So provide them with that routine so that they becomes familiar, and then routinely they will gradually imbibe in that routine, and probably then the level of functionality will improve. They're all these stimming and independent, because all these behavior happen when they are ideal. Why they are ideal? Because they don't have anything to do. Why they don't have anything to do? Because they don't have skills to do the task independently. When they are able to do the task and skills independently, probably they will learn the functionality of those skills, and probably those behaviors and those things will come down, and then you can go for independent schedule. So all these things we have discussed, communication tools, that is what I have talked to you, how you need to provide the command, what scheduling you need to provide. And at the last comes the medication. Now medications I have been put at the last because many a times 95% of the cases will be resolved when we look into these behaviors, unless and until medications are required if there is a medical problem, if there are any adenoids, if there are any colics, if there are any upper respiratory tract infections, if there are any fevers, if there are any medical problems, if there are any injury, um, fever or anything, but or any medical diagnosis. At the last, in less than generally in my practice, I generally give it less than 1%. I prescribe Shizodone or Respirodone to them, because again we need to look out that what is the age of the child, Obviously, a 3-year-old child, non-verbal, high sensory issues, is throwing things, running here, not sleeping, doing mischief. I cannot prescribe Shizodon for that child, because a 3-year-old child with no such abilities, how you can, accept that this child will sit quietly or behave in a socially, because it doesn't have any skills. It doesn't have any skills to communicate. It doesn't have any skills to play. It doesn't have anything. So we need to figure, and then probably similarly, if there is a 11-year or 12-year-old child who is doing so much mischief, head banging, throwing things, in that probably I would prescribe a medication rather than telling the parents or others to look into the antecedent behavior. So physical challenging behaviors, as I've discussed, all these are biting, pinching, slapping, spitting, hair pulling. These are all considered to be physical challenges or self-injurious behaviors. So these things I've again discussed all this. So another important thing is communication tools. Now, because children on autism, they have difficulty in communications, so you can provide them with visual charts. As we have discussed, because they have a very good brain mapping, they are visual learners rather than auditory learners. Or there is another technique which is known as PECS, that is picture exchange communication system, which is generally used when a child is non-verbal and we have crossed a certain age where the child also loses his motivation to speak and talk. So these are some of the alternatives modes of communication which needs to be done depending upon the level of severity of communication deficits. Obviously, you cannot prescribe PECS for a 2 to 3-year-old child. It depends, because generally PECs and those things should be prescribed if the child is beyond 6 to 7 years age and is still non-verbal and with finding it a lot of difficulty. And generally they have been prescribed generally in cases of very severe apraxia. Generally, then another thing is prepare for change. Many a times children, if they want to go a route A and they will not follow route B, if one day you follow route B, they will get irritated because they have very fixation obsessions. So whenever you are preparing them for a change, you prepare them, provide them with an anticipation. Okay, provide them with visual charts. Today we are going to school with route A, tomorrow we'll go with route B. So their mind gets anticipated. They are not prepared for any change immediately. You need to provide them with a certain time processing that and make them understand, give the time to their brain for that particular change. If you provide a change instantly without any notification, it becomes a problem for them. So prepare their mind. It's also like that today, suppose he's very comfortable in his house, he sleeps at 9 p.m. in the evening, and suddenly he goes out to an uncle's or a nana's house and there he sleeps. It becomes irritable. He mess, he screams, he shouts. He's not the whole night, he just screams and shouts. I don't know what is the reason. So probably the reason is because he's not comfortable with the change in their mind. So in that case, probably many a times they might be not comfortable with the texture of the clothing of the bed. They might not be comfortable with the brightness of the room. They might not be comfortable with the texture, the surroundings of the room. So prepare them, anticipate them, prepare them with visual charts. Tell them we are going to the next place. Again, depending upon how much receptive skills they are having, you can either give them a auditory or a visual, depending upon the level of communication and depending upon the level of severity of deficits. So again, most important thing which comes is temper tantrums. Now, temper tantrums and meltdowns generally start in a same way. But what is the difference between the two? Temper tantrums are considered to be something normal which happens in a certain toddler age group. But when those happens beyond that age, then we call it as tantrums. But whether those temper tantrums are meltdowns in an autistic child, because temper tantrums can happen in a neurotypical child, that we can able to differentiate very easily. But when temper tantrums happen in an autistic child, are we able to differentiate whether this is a true temper tantrum or it is a true meltdown in an autistic child? Because it's not always that a children on spectrum will always do meltdowns. They might be they might be tantrums also. So we need to differentiate whether it is a tantrum or a meltdown, because our approach will accordingly vary depending upon what is it. So what is tantrums? Now, temper tantrums are unpleasant and disruptive behaviors or emotional outbursts which occur in response to some unmet needs or desires. So tantrums are more likely to occur in young or others who cannot express their needs or control their emotions when they are frustrated. So tantrums always are tangible. Tangible means they are showing the behaviors in response to something. They want that, show they are showing a behavior. A very simple example to make you understand, we'll be going to the details. is the mother has gone into a mall and the child wants that toy. He will be keep rolling over the bed, running on the floor, jumping, screaming, shine. And once he gets that, he will settle down. So that means he has shown that behavior in response to some certain thing, what is known as tangible behavior. If on the other way, if it would have been a meltdown, the child is screaming, shouting, running, rolling over the floor, head banging, and is just pointing to that green car. He wants green car, and that happens till 30 minutes to 25 minutes. Ultimately, the mother, loses all his, what do you call, say, loses all his temper, and ultimately he gives that red card. But the child continues to cry, scream throughout this whole 2 to 3 hours, and ultimately, after 4 hours, he settles down by himself. So, what is that? That is a meltdown. So, when we look into the meltdown, meltdown has three different stages. So, we'll be going to that. And whenever a meltdown happens in a child, you need to intervene at a certain level of the stage. Because when you intervene beyond that certain level of stage, there is no point in restricting the meltdown. It might get worse. Because meltdown, when it happens, it is a self-limiting step which will limit itself by a certain period of time. You can only intervene only up to a certain stage of meltdown. When that stage of meltdown crosses, it becomes a self-limiting behavior, which will come down maybe after 2 hours, 3 hours, 4 hours, depending upon the level of severity of meltdown in that particular child. I hope I have made myself clear in this. So, for children with autism spectrum disorder, tantrums might be triggered for a variety of reasons because many children with autism have difficulties in communication, socially acceptable ways. They may come out when they are confused, afraid, anxious, or stressed out. So, tantrums can occur when a child needs not being met, such as information, sameness, and tangible. So, means to say, tantrums more commonly happens because of a tangible, in a desire for something. So, what to do when tantrum happens? So, normally when a child has a tantrum, it is important that you stay calm. Remember that tantrums are normal. So, many a times tantrums are basically considered to be tangible behaviors. There are two approaches. Either you ignore the situation and let him cry, and after a certain period of time, it will wane off, or you provide with the material desire or tangible thing which he wants, and he will come down. So, these are the two things we need to approach. Now, that totally depends upon how you want to go it. Sometimes if you provide with the tangible thing, the tantrums might keep on increasing. So you need to limit yourself whether that tangible demand which is there for the child is right or not, whether it is logical or not, and accordingly you need to intervene because tantrums after a certain period of time will automatically glow off. And that certain period of time is very, very less compared to the meltdown. That is one thing. So either provide with a tangible thing or just leave that thing. If you feel that is not required, it will come down. So you need to intervene by providing the tangible thing or just avoid that because it's a type of attention seeking behavior. So this is what we do when we look into the other methods of tantrums include use an upbeat tone when asking your child to do something, make it sound like an invitation or not an order. It's very, very important thing. uh, the child is writing on the child is writing on the child is drawing on the with a pencil on the wall. You are telling no, don't do it. He continues to do, and ultimately you tell after 5 to 10 times, don't do it, you just give him a slap. Ultimately he screams more, he shouts, and all the mess happens. So first and foremost thing is, depending upon his level of understanding, you need to provide them with a logical reasoning rather than saying don't write on wall. Just reframe your sentence. We should not write on a wall, we should write on a paper. So at least he knows where to write rather than telling don't write, because his brain is don't write, then where should I write? This is I'm talking if there is a normal toddler age group. Okay? Because they generally start scribbling with the wall. You just tell him don't write on the wall, do not do it, it will get dirty. So where to write? His brain asks where to write. Nobody has told me where to write. So you just need to reframe your sentence. Don't write on the wall, we should write on a paper. Probably in 2 or 3 attempts he will start to do it. And you should give your attempts at least for 8 to 10 times before you accept a response from a child. This is even for a normal typically growing. You provide, in a complementary feeding, when we start feeding with a solid feeds, normally complaints come, sir we मैंने आज इसको ये नई चीज खिलाई, इसने खाई नहीं, मैंने ये खिलाया इसने खाई नहीं, आपने कितनी बार ट्राई किया? सर मैंने 2-3 बार ट्राई किया. There is a golden rule. At least you need to provide at least 10 tries. You need to provide 10 trials of some new food to the child And if he resists, or then he resists, then probably you need to change something other. Before that, you cannot tell that he has not taken, or he has not, or he has refused it. So similarly, it applies to this thing, that you need to provide at least 8 to 10 trials of your way of expression, how you tell the thing, how you provide logical reasons to the child. So do not battle over an unimportant things. As I have told you that, okay, I want to wear the shoes. No, you wear the shoes. You wear the shoes. Just don't tell them, no, wear this. No, wear that. You need to provide some logical reasoning and the reason why you are telling it. This is very, very important whenever you are doing it. And always provide them with the choices. Okay, you do this, you will get this. So use other things, pairing, unpair with pairing things. Okay, you want to do this, I want to watch TV. No, don't watch TV. You have watched 100, we have watched so many times. Again, they will be messed up. Why should I not watch TV? You also do WhatsApp throughout the day. Why should I not do it? So you provide a reason. Okay, you complete your task, complete your homework, then you watch TV. Probably he has some reinforcer. He has some reinforcer in him that, okay, mama will give me a TV when I finish that task. So you need to approach in a different way rather than just jumping on the behavior and telling no, or just avoiding it, or slapping and abusing and all those things which normally happen in every house. So this is about the tantrums when I talk about neurotypical or in autism. Now let's understand what is a meltdown. A meltdown basically happens due to an intense response to an overwhelming situation. It happens when someone becomes completely overwhelmed by the current situation and temporarily loses behavioral control. So one and foremost thing you should understand is meltdowns are not under his control. He is not doing it intentionally. It is being occurring in response to the body response to the environmental situation. So it is not under her control. Tantrums are under her control. Many a times children will see mother is there, I will start screaming more. Mother is there, I will start screaming more. It is an attention seeking or a tangible thing or a behavior which is happening in that response. Just give me a second, please. Yeah. So that is what we need to understand, that tantrums and meltdowns. So this is very important stages of meltdown. Now rumbling stage. There are three stages of meltdown: rumbling, rage, and recovery. So this is the meltdown stage where the child goes. So all these stages of are known as stages of meltdown. Unless and until we are not able to understand the stages of meltdown, we cannot manage a child on meltdown, because we will not know that he has which stage he has crossed. Now the rumbling stage is the initial stage where the child will give you some indications that now he is going in the next stage. Like during the initial, the child exhibits some behaviors that may appear to be minor, such as nail biting, tensing muscles, otherwise indicating discomfort. There might be redness, there might be increased breathing, shallow breathing. He might be difficult. You might see he's not comfortable in the environment. He is giving you some clues that I am not comfortable and struggling with this situation. His muscles might get tense. You might see that the child might start doing his hands. He might just fidgeting, he might be doing here and there, he might be roaming. So he might start jumping on the floor, he might start rolling here and there, he might be curdling, he might not be comfortable in his standing posture. So all those indicates the rumbling stage. That means he is not. Now this is the stage where you need to intervene. Now, rage is the next stage. Now, rage is some stage which goes beyond the control of the child and beyond your control. Because in this stage, child shows or child is emotionally disturbed and he goes explosive and he screams, shouts, throws on the jumps, running here and there, destroying things. And if you intervene here, there is no point, because that is gone beyond the stage of rumbling. When it goes into the rake, it becomes a self-limiting stage. And then after a certain period of time, depending upon how much prolonged the rake goes, whether it may go for 2 hours, 5 minutes, 10 minutes, depending upon the level of varies from child to child, the child will ultimately go into the stage of recovery. The child with ASD often cannot fully remember what occurred during the rake stage. Some may become sullen, withdraw, or deny inappropriate. So many a times when the child comes out from the stage of rake, they might sleep for a certain period of time. They might just sit at the corner of the house very quietly without doing anything. They will not be liking to talk with anybody, or they might just hug the mother and sleep comfortably for 1 hour, or they might just continue to hug the mother or caregiver for 1 hour or 5 hours. important that if you try to ask them, recall them, they will not know what has happened, why did it happen, and you will feel like, oh, I'm so amazed. At 1 hour before, he was so mischief, and now he's obeying all those things. He's doing all tasks. At that particular time, I was feeling he doesn't know anything. He was totally a complete person. That is what the peculiarity of this meltdown. So you need to understand these are the stages. Stage 1, 2, and 3 are the stages which define you the rumbling stage, where you can intervene. Stage 4 and 5 are the rage stages. This is the peak where it starts hitting, biting, scratching, hitting others. You cannot intervene at all. Where stage 1, 2, and 3 are considered to the rumbling stage, where you can intervene the child, whereas 4 and 5, once he crosses, you cannot intervene. So this is not a time to ask a person to make choices. Modeling calming strategies will not help in this stage. It is only the stages 1, 2, and 3 where it will give you an initial clues. Mama, I'm not comfortable. Let's go out. Mama, please go out. Mama, I don't want to stay here. He starts fidgeting, he's rumbling, he's tense, he's not comfortable, or he starts doing pushing. What are you doing, son? These are the indication that he's not comfortable in the environment. So just take a clue, and these are all the clues which is giving, because he's not so much verbal to explain his initial senses. So he's just giving you visual cues and physical cues to get me rid out of this situation. And if you are able to look at that, you are well and good. Otherwise, he will ultimately go in a stage of meltdown because it's not in his control. So that's what the thing is about meltdowns. So when he goes into the stage 4 and 5, that is known as the rage stage, you cannot do anything. Let him happen. Just ignore him. Just let him do what he's doing. And after a certain period of time, unless and until he's doing a self-injurious, if it is doing hitting, biting, pushing, and causing self-injury, you need to intervene. And then it is a 4, 3, 2, 1 is a recovery stage, which generally happens. So this need to be understand, and then you need to figure it out what is happening in that child. So I have told you all these stages, that is give time, calmly talk, make him space. When he's in the recovery phase, either you can hug him, you can make him in a closed environment, you can give him an isolated, calm, peaceful environment so that he sleeps, whatever he wants to do. Because many a times after this, they will go in a prolonged stage of, very silence or in a very relaxed state. So these are all the sensory consideration, change in routine, that is independent scheduling I have discussed you, dependent scheduling I have discussed you. So how can you tell an autistic meltdown from a tantrum? So I have told you the most important is tantrum is always goal oriented. That is tangible. I want this, so I'm doing this. Whereas meltdown is always in response to the sensory overload which is happening from the external environment, which is not under my control or is being overwhelmed. So this is most important thing we need to differentiate it between the two. So another thing, tantrums is happening in response to the audience or the target. That is, अभी ये crowd में है, मम्मा पापा मुझे कुछ नहीं कहेंगे, अंकल आंटी है, मैं tantrum throw करता हूँ, मुझे टॉय मिल जाए. But meltdown doesn't happen. Meltdown is not in response to any audience or anything. Meltdown can happen even in a single room because of that brightness, because it is happening in response to the sensory stimuli which is being received to that particular child from the external environment. So that external environment doesn't need to be crowds. It can be simple brights. It can be simple sound. It can be simple music. It can be a simple crying of an infant. So that much explosion can happen in a child on the spectrum when he's doing a stage of meltdown. So addressing behaviors, again, I have told you that we need to obtain ABC approach, which we have discussed. Now, this is the diagram which I wanted to show you in discrete trial training. As I've told you in the initial 3-4 slides, go to the kitchen. The child might not be able to understand. He may go in a state of meltdown. So first and foremost, whenever you are doing, the first important thing is establish eye contact. Once the child establishes an eye contact, give a very simple command. Go to the kitchen. Now, then you need to wait for at least 30 seconds. Now, 30 seconds is the time which needs to be understand. If it doesn't able to understand where is the kitchen, give him the clue. Now, clues means give him the prompts. Either you can give him visual prompts, you can give him verbal prompts, or you can give him physical prompts. Visual prompts means you just pointed kitchen, kitchen. That is visual. Prompts, verbal prompt means there is the kitchen, go. Physical prompt means you hold his hand and take him to the kitchen. And once he complete that task, but bring water, you give him a reward, either in the form whatever reward. It can be materialistic or it can be non-materialistic, that is praising him. So these are the stages. Give an eye contact, give a single instruction, wait for the processing for him for 30 seconds, and then if he's not, provide with a prompt and give him a reward. So these are the 5 stages when we follow a discrete trial training. Now this is an evidence-based practice which we need to follow when we are providing instructions and treating a child on spectrum to give instruction, understand instructions. So this is discrete trial training is a method of providing and improving receptive skills, receptive language in a child, because no child will provide expressive speech unless and until there is a receptive speech. So again, thing is day scheduling. As I've discussed, you provide with day scheduling, visual timetables. What is the duration? What at this time you need to provide, because the brain is anticipating that. They knows that what will next come. If immediately you give them, okay, your time is over, now play, now go to kitchen, now go to market, now go to school, he will get irritated, he go into a meltdown. But when you show him the visual, at least his mind will be prepared, his brain will be prepared, what next, because they need time, they need preparation for the brain. So that is why I provide them visual schedules. So this is all about these behaviors. So thank you very much. And just a last slide about this reinforcement ABC approach. As I've told you that what is positive reinforcement, what is negative reinforcement. Positive reinforcement means when you provide something to the behavior so that you get a desired behavior. Negative reinforcement means when you remove something from the behavior in order to attain a positive behavior. Punishment means when there is a negative behavior is happening and you provide with a negative consequence, that is punishment. Extension means when a child is doing a negative behavior and you ignores it. Just give you an example. For example, a child is writing on the child is scribbling on the walls, and you provide him with a book. The child starts writing on the paper. So it's an example of positive reinforcement because your ultimate desire was to write him on the paper. Now, negative reinforcement means the child is writing on the wall, but you remove that piece of wall or whatever, and he stops doing that task. So probably it's an example of negative reinforcement because he's not doing it, or probably you provide him with, you remove that task and he's doing something on the wall. Punishment is he's writing on the wall and you gave him a punishment. Okay, you go out from the room and stand there. Extension is he's continuing writing on the wall, but you are just ignoring and ran away from there and ultimately stopped doing it. So these are all the different ways of approaching the behavior. This is what is known as reinforcement theory of motivation. So that's all I wanted to tell you. So this was a very brief about managing behaviors in autism, though it's a very difficult and elaborate topic, but I tried to make it concise during this short period of time. So thank you very much. And if there are any questions, we can take it for 2 minutes and then we will close up the session as we are already running on time, please. Now, one question is there, can meltdown be seen in a non-autistic child? Now, generally it is not seen, but generally it is not seen. Generally it will be no, but yes, if the child is having sensory processing disorders, which might be related to sensory modulation, sensory restoration, or sensory maturation, meltdowns can happen because generally meltdowns happen in relation to the sensory stimuli. So ideally, if you ask, it is no, but majority of the times it generally happens in autistic people. Any other questions from the participants? And there was also one question regarding the recordings. Recordings will be provided at the end of the summit in the group. So parents, delegates who are not able to attend the live sessions, we will be providing with the recordings at the end. So I will close up the session if there are no questions for today.
I have a question.
Yeah, please.
Sir, if the cause of the behavior is like sensory, so for example, like I have one of the kids who used to take out clothes when she used to go home, but that is not the behavior at public places. So I thought there were, I mean, I actually assessed and I saw that there were a lot of tactile issues. So I went with the sensory management and all. Then we later on, now as the child is progressing, I had to build up new adaptive responses and other skills. So I kind of, laid a little less emphasis on sensory management, rather tried to work more on other skills. So that behavior now it came up again. So I just wanted to know ki what should be the kind of approach. It should be a top down or bottom up approach, and how to analyze. Like you said ki if it is not intervening in the performance of the day to day task and other skills, then we might allow. Say for example, you said ki if that particular behavior is happening because of emotional, as a part of emotional expression, you allow the child. But this is kind of something, some sensory stimuli is so much overwhelming. So now it's so much of cold here, and if the child doesn't wear clothes or remove clothes, and that kind of behavior it comes up again, then what should be the approach in that case?
See, again, you need to figure it out. You need to tailor it down, whether this is happening, whether it is affecting his daily routines, whether it is not affecting his daily routines, or whether it is affecting his academic learning. Now, as along with that, accordingly, you need to take a call that whether at what level of stage I need to intervene. Now, suppose as you have told that the child is gets very excited. The child gets very excited when he sees some rhymes on the TV. So instead of that, we can provide him with some replacement behavior. Though I have not discussed in today's topic, but you can provide them with an alternative source of behavior, what is known as replacement behaviors. So we know that replacement behavior is something. The ultimate aim of replacement behavior is to provide a desired behavior which we want as a result of particular action. So for example, child is very happy to see Peppa Pig rhyme, and he jumps, starts hand clapping. So instead of that, we can provide with an alternative behavior or replacement behavior that we should not jump, we should not hand clap, we
So
should
may I
just clap.
excuse you, please? So may I
Yeah.
excuse you, please? But sir, in this case, the child is going home and removing all the clothes. She's not ready to wear clothes at home. So and she's wearing very little clothes, like, and so much of cold here. So she gets overwhelmed with clothes. I suggested that to give them like lycra clothing, but then again, it's not protecting them in winters. And she's not doing that behavior in public places as such. I told you. So this is not going to impact as such learning and other skills, but then it is a kind of sensory overload. I have been giving sensory diet as such, but then still she continues to do that at home.
Okay. So you have figured it out. That's a sensory cause, but you are not able to, tackle out that problem that he should wear the clothes. Am I right?
Yes, sir. So that's what I'm saying. Ki
Okay.
it's just like I have suggested them to use heaters and other things, because in case if the child is not
Have
ready
you,
to cope up with
have
that, I
you,
thought the environmental accommodation can be the approach. That is what I advise them. But then, should we
have you
force the child to wear clothes? That's what I'm asking.
No. See, obviously, you have to make him wear clothes in winters. If in winters he's not wearing clothes and you have figured out it's a tactile, have you tried Wilmaga brush?
Yes, sir. That's what I told you earlier. I was giving him when I was giving her, the sensory diet in general.
Hmm.
So that
Hmm.
thing had that thing was I intervened, and she was able to get cured. But then now again, this behavior has come up after 1 year,
Okay, see
because
what you
I'm
can do.
working on other higher skills.
Hmm.
Huh.
See what you can do. See, definitely the things which happen, there is always, that sensory waxing and waning happens. Okay. Now, from your point of view, just by listening to you, definitely sensory waxing and waning can happen in their child. So, what you can do, you can provide them, you can advise them wearing clothes for some period of time and then removing, wearing and removing. So, teach him, provide him with some set of exercises rather than okay, it's winter, you have to wear your clothes and throughout the day he wears, and then you telling him to remove at the night, it becomes a difficult task for him. So provide him with certain intervals for a certain period, say for 15 minutes or 20 minutes, or maybe for 2 hours he wears the clothes, then give him an exercise, okay, removal. So probably when he's wearing the clothes, he might be able to tolerate it only for 2 hours or maybe 30 minutes, and then he goes into a state of sensory overwhelming response, or he's not comfortable, then he needs to remove the clothes. So provide them with those activities of removing and wearing, and in between provide them with the Wilbarger brush which you are doing, so that probably it might give him some relaxation during that phase. So whenever you can advise the parents also that whenever you are making him wear the clothes, just before wearing the clothes, give him that Wilbarger brush massage, and then give him a wearing of clothes for a certain period of time, maybe 1 hour, 2 hours, and then remove it, so that he doesn't go into that stage of overwhelming response where he himself starts removing the clothes and not listening to other. So that stage you need to intervene. Before that thing happens, you remove the clothes, act passively, rather than he goes into the stage of active removal. I hope I hope you are able to understand. And
Yes, sir,
then
I got it.
and after then give him a certain period of relaxation, that is removing the clothes. This is where he will make himself calm down, because now there is no tactile response, tactile disturbances, overwhelming response to the clothes. And then even settles down after 2 hours, again repeat that exercise, use the Vilvaga brush massage for a certain period of time so that it gets relaxed, comfortable, and then wear him the clothes for 2 hours, and then judge the period where he gets actively removed. Just before that, start removing the clothes so that meltdown doesn't happen. So gradually his period of tolerance of the wearing clothes will increase. So this is basically what we are doing. We are trying to provide him with an exposure therapy. Okay.
Okay, sir. Thank you. Thank you, sir.
Thank you. So I think we'll close up with the session, and if there are any queries, we can put up in the group. And thank you all the delegates for attending today's session. Thank you very much.